So we all talk about how we use OCT at follow-up. What type of features on OCT are you looking for to decide whether to retreat if you're using PRN, or are they dry in a treat and extend? So what are you looking for?
I typically look for the two main criteria are visual acuity exam, then intraretinal fluid or subretinal fluid or cystoid macular edema. If it's just a serous PED, I don't know. I count that as pretty much dry. If it's a fibrovascular PED with some irregularities and some fluid at the tails, then if it's not in the center, I might still extend them a week at a time or a few days at a time. But it's really the cystoid macular edema, subretinal fluid that I look at, and the PED. If it's a serous PED with nothing else, I pretty much say your OCT is dried out.
So one interesting thing that came out of a CAT study in terms of the OCT data was they said that the intraretinal fluid over the fovea correlated best with vision. And we've all talked about doing the macular cube. So do we really need to chase, say, some cystic changes 3-4 millimeters away, or is it really and can we just use the foveal scan, which is implied by what CAT is telling us? What do you think there, Jason?
Well, I think that goes to exactly what we were talking about earlier about how tight of a PRN do you want to use. I think that the fact that there is fluid somewhere in the macula indicates that the patient is producing VEGF, that VEGF is being produced. And while today it may be cysts, 1,000 microns from the fovea, a week later there may be cystic changes over the fovea. And I think that it's a clue that there is disease activity in the macula, and I think ultimately our goal is to try to eliminate that, unless you want to see the patient weekly to monitor to see when that shifts over. So I think that's one of the keys, that to me any kind of fluid in the macular area is an indicator of biologic activity, and I would like to suppress that.
And I think, and the other, in addition to that, for me, I'm concerned about hemorrhage. If you have an active, if it's a juxtafoveal lesion and you don't have that, you've eliminated the foveal fluid, but you still have a little bit of fluid going on outside that, your concern, especially, in a PRN or a treat and extend regimen, is the devastating submacular hemorrhage. And so if you have ongoing CMD activity, that's a concern. One of the challenges, I think, for any of these on-label regimens is I think all see these patients with a little bit of fluid that never changes, and that might be extrafoveal, whether it's subretinal fluid or intraretinal fluid, and how to deal with that. I find to be a real challenge, maybe over a little atrophic scar is that dynamic fluid, is it related to VEGF, is it just chronicity, and that I think also poses a real dilemma in terms of follow-up and treatment too.
At what point do you call that outer tubulation versus cystoid macular edema?
I think you can kind of distinguish outer retinal tubulation from edema, but I think the hard part is exactly what was just said, was what do you do with this fluid over a scar or over atrophy? And I mean, what we do is I'll bring the patient back in a week or two just to see if it's a durability effect or if it's therapeutic. Exactly. If at the end of a week to 2 weeks there's no change and it's over an area that's clearly atrophic on SD-OCT or clearly over an area of fibrosis that you consider to be essentially non-functional retina, I won't that to me is a stable situation, because it's not something that's going up and down. You're not modulating that. So it'll kind of go into a little box of, all right, I'm going to pretend that's not there and then look at everything else. But I do want to know that it's not changing at that early stage.
Yeah, that's exactly what the way I look at it is it a VEGF-driven process? And the interesting thing is I have had, and we're going to get towards some of the switcher data, is that I've had a couple of patients where that part had been stable for a long time, and I wasn't counting it, and I switched them for various reasons, and it went away.
Yeah.
Which is interesting.
So you brought up a good point. What on OCT or vision or number of injections do you use in your mind to say a patient is not responding to the treatment they're on?
Yeah, Peter, could I just make one more comment about
Sure.
OCT? In the year 2013, being a retina specialist is difficult because we have such a wealth of data from so many clinical trials and diverse in many ways. And I really believe it's safe to say we have a lot to learn about OCT and how it should guide our treatment regimens. Now, the reason I say this is that you've heard many times in this discussion that we want a dry OCT. And CAT studies showed the more stringent the protocol, the drier the OCT, the more effective the vision gains are. But there's a very interesting finding in view 1 and view 2, where the sawtooth pattern was brought up earlier in the discussion by Justin, where the every other month dose of aflibercept had a fluctuation in OCT between 25 microns early on to maybe 12 microns by the end of the year. But if you really look at it carefully, by the end of year 2, do you know which group had the driest OCTs? The every other month aflibercept group. They had the driest OCTs with less injections. How does that make sense? How do we bring it together? So I think that a little fluid is tolerable. Does it really translate to better vision? Some trials tell us, yes, you have to keep it dry, but then you have view 1 and view 2 where you can get away with less injections. And at the end of the year, even though we see the fluctuations in OCT, they still do very well at the end of year 2.
I would just make one caution. There's some sub-analyses that will be coming out that have indicated that if you do have this fluid and you really subdivide, again, we're looking at big groups, if we subdivide these populations, it may be that if you have fluid, they may not do as well visually. So I would just put a little note of caution that, again, as a group, it may be behaving that way, but when you really look at them carefully, it may be that fluid present at certain time points is probably in the end not a good thing.
So and the other thing with the second year of view, when they went into the CAP PRN regimen, they were still seen monthly, and in those patients who were in the Q2 month, if they had fluid, actually could have been treated on a more frequent basis than they were in the first year, which may have been part of the reason why they dried up.
They dried out, yeah. And that's what I'm saying. You have to look carefully at the data. There'll be some more analyses coming.
Clearly have a lot to learn.
Yeah.
Well, and the other thing I think the sawtooth pattern indicates what we talked about before. It's individualized treatment. There's some patients who just do just fine on maybe every 3 months or every 4 months treatment, and even in the VIEW study, there were patients who needed or should have maybe had injections monthly.
Right.
And so even with EYLEA, where we think it lasts longer, and in fact we have some data to support it, it's individualized.
Right.
And you can't just say, this is how we do it. Each patient is different. Harbor showed it very nicely in the PRN arm. If you look at the number of treatments in the PRN arm, there wasn't a bell curve where there was a certain number where the patients did really well. It was distributed across. I mean, some patients need 2 or 3 injections, some needed 24, and there's no way to find a baseline who's in the 2 and who's in the 24. So getting back to the question of non-response, how do you define non-response?
Single biggest diversity of opinion probably in our field right now. I considered there are different levels of non-response. There's what I call lack of durability. There is what I would call partial response and true anti-VEGF non-responders. The lack of durability is a patient who gets an injection of, for example, Lucentis. At week 2, they're dry. At week 4, they're leaking. I mean, that's someone who's responding. They're not non-responders. They're simply leaking at a time that you would normally expect them to be dry using Lucentis. A partial responder is someone that has less fluid, but never goes completely dry even at 1 or 2 weeks, and then kind of has that curve of going down and then coming back up again. And then there's the true non-responders, and I think that's a small minority of our patients that don't do anything, that you give them an anti-VEGF and then just kind of the retina waves at you and just doesn't change. I think that's a small fraction of the patients we deal with. I think most patients with any of the drugs show some response, and then the question becomes which one's going to work better for that particular disease pattern. So I think that's kind of the pattern. As far as what constitutes non-response, cystic changes, subretinal fluid, and as Justin mentioned, we're starting to get into the area where maybe now that we have EYLEA, we can start to even talk about the RPE detachments and some of these more chronic fluid situations. So I think we can look at all of them as potential ways to look for to fit into these 3 categories.
One of the interesting things, as we talk about what defines response, one of the things that we don't talk about is vision, because it isn't really part of it. But when we talk about how are you doing, in the end, what really matters is vision. But we can have people who respond brilliantly to the drug, and the vision doesn't budge, and that's something also that, as you think about, when I think about switching, drugs and all that as well, it's the one other part of it that the patient comes back in the most with, and it's the hardest to predict in a lot of these patients and what effect that has.
But you can also have those OCTs that look scary. You're like, PED, or subretinal fluid, and you're 20/25, and like it doesn't budge, but you're like, you're doing well. Do you call that, it's a failure patient to treatment on OCT, but their vision's still 20/25 and the goal is maintenance of vision, I mean, I would say, hey, let's not rock the boat and let's keep you where you're at. So there's also that flip side.
Right.
Mm-hmm.
So, Justice, you have a lot of patients who start off with Avastin. At what point do you say, oh, they're really not responding to Avastin? Is there a time point, or is it really a gestalt thing?
Again, I think the thing you have to remember is the heterogeneity of our patient population. There is no, I think, cut and dry definition of at this point we know you're not going to respond, because there are patients, and we'll talk a lot about, if you treat them monthly, that at month 6 or month 7 they might become dry. From a comfort, so in the end, I think it becomes more of a comfort and judgment call on your standpoint on any of these drugs. What are we seeing from an effectiveness standpoint? And for me, if by 3 months, honestly, at a month, I'd like to see a little bit of response. I don't necessarily want to see them dry, but in most patients, you come back and you see improvement. If it's 0 response, I start to think about my diagnosis. And I think that's the other part about the non-responders is then you really want to be sure you've got the right diagnosis of choroidal neovascularization, whether and hopefully that it's whether it's AMD or whatever you're looking at. But for me, if at 3 months I've gotten my response is suboptimal, both from a vision and anatomic standpoint, that's when I start thinking about changing what I'm doing.
And what do you change to?
Most of the time, I'm changing to Eylea at this point. Again, I talk with the patients about it. I've had patients who will say, I want to go with the one that's been around the longest, that has the greatest track record, and then we go with Lucentis. And others, it's funny, I had one patient who, she's been treated, she's been on monthly Lucentis for the last 2.5 years. And when Eylea came out, I talked with her about it, and she said, one of my friends had an issue, and I don't want to switch. And she came back about 2 months ago, and she's had persistent fluid, so she's a suboptimal responder, but she has disciform scars in both eyes. We're keeping her at 2100 in the one eye. She comes back in, she said, I want to try switching. And I said, oh, that's great, we'll try it and see. And she said that same friend is doing great on it. And so there is some, for me, anytime you talk about switching, as Atul mentioned, you are rocking the boat and you're changing a direction, and you want to have the patient engaged in that decision.
So you guys all start with Eylea. Do you switch from Eylea to Lucentis or Avastin?
I've had a couple. And I think, and again, it goes to the fact that there never say always or never say never. Sure. There are going to be individuals who are going to respond for whatever idiosyncratic reason to one drug better than another. I have a couple of patients who were started on Eylea and seem to be doing better on Lucentis. So there will be individuals. I've had a lot more where I've converted from Lucentis or Avastin to Eylea and seen a fairly dramatic response. So I think that, that's the reason I start with Eylea. I kind of weigh all three and say, all right, this one seems to do a little better than this one seems to be a little safer than this one, therefore I might as well start with the one that I think is maybe better in some people. But I'm not married to one drug, and if it looks like they're having a suboptimal response to that, I will try a different one. And to me, it's not going up or going down, it's just shifting, and be fortunate that we have 3 tools to choose from.
Yeah.
I did. There's a study I submitted. It's data. I can't speak specifically about it, but I found that, we say there's a complete responder, their OCT dried out, exclude them, and there's now if there's a failure patient, exclude them. Now we got this group of incomplete responders that have some fluid. We don't know really what to do, and they're on bevacizumab or Avastin and Lucentis. And when I converted them to Eylea, I found that I could get mild improvement in vision, but the take-home point is I looked at it at 6 months out. It was basically 2 weeks further that they could go without an injection than they did on either of the other 2 drugs. So what I learned from that is switching them to Eylea kept their vision the same or slightly better, but they got a 2-week extra break between treatments from me. And I think that's huge, because if they were coming every 4 weeks, it's 50% less they have to come in. Transportation and all these things are a huge benefit.
Yeah, I think there's one other group too for me that I see is that those who have appropriate response at the beginning, and over time that response attenuates. And I think that's a different, it may or may not be, I sort of suspect it's a little bit different issue than the people who are suboptimally responders from the beginning.
Atul brings up a very interesting point about suboptimal responders. Is that, first of all, we have to define it from the patient's perspective and our perspective. Okay, that is two completely different viewpoints. So we have to communicate with our patients about what they're looking for in terms of therapy. But suboptimal responders, the funny thing about it is that there's so much discussion about defining what it is, but when we see it, we know it. And it's either the vision, it's based on visual acuity, it's based on the dosing frequency is not as good as we would like, or imaging. Okay, that's really what it comes down to. And so because of these variables, the three different variables I spoke of, patient's perspective and the clinician's perspective, it's a very hard thing to define. But really the options are so limited. Okay, number one, you can increase the frequency. You can, maybe go every 2 weeks of Avastin, 2 weeks Lucentis, but the burden is so ridiculous. I mean, it's a very, very high treatment burden. You can increase the dose. Okay, look at the Harbor study. Really showed no effect doing quadruple dose Lucentis. A SAVE study showed some possible benefit. Or you can switch to aflibercept. And, those really are the options that I see. You asked about patients I start off on Eylea, what I do if they don't respond as well. I back up from every other month dosing to monthly dosing because View 1 did show a benefit, a statistically significant benefit of monthly aflibercept over Lucentis monthly. So I do utilize that at times, and sometimes just pushing forward with treatment, you will reach your end goal. But this is a complex issue. There's no doubt, very controversial, a lot of discussion. But Jason, gave a very nice description of suboptimal response. Probably the best definition I've heard so far on this topic.
You let me say more than 3 words.
Yes, and that helps.